you recognize it earlier and treat it earlier. The access to advanced therapies like mechanical circulatory support can significantly influence the mortality rate. So what are the clinical manifestations of shock? If we want to answer this, you can put it into the chat. We can have a little discussion and then go over it.
So feel free to start listing some of the clinical manifestations of shock. You can put it in the chat box.
Perfect. I'm seeing hypotension, dyspnea, poor perfusion, tachycardia, palpitations, altered mental status, low blood pressure, confusion, cold extremities, amazing. A temperature gradient, hypoglycemia, weak pulse, oliguria, yep, decreased urine output. Yep, these are all exactly what we will talk about. So as you can see here, so inadequate perfusion. So we measure that by blood pressure. So if our blood pressure is less than 90 systolic, or our MAP is 30 points below baseline, then we can say that patient is having inadequate perfusion. The other thing is if our lactate is elevated, usually above 2, then we can say that we have inadequate perfusion. And then like other people were saying, cold extremities and diaphoresis or sweats can be another clinical manifestation. All of these can be data points to see what an organ dysfunction is happening. So we can have altered mental status, confusion, anxiety, dizziness, fainting, and even a coma. We can see that we have low urine output, we have fatigue, shortness of breath, and some people have chest pain.
You are muted.
Thank you so much, Pauline. Apologies, everyone. So one of the objectives that Dr. Sarah mentioned is that we want to be able to recite the equation and understand the equation for blood pressure. So we know that blood pressure is cardiac output times the systemic vascular resistance, or the resistance within the blood pressure. Cardiac output is the amount of blood that the heart pumps within 1 minute. The volume of blood pumped out of the ventricle in one beat is called the stroke volume, and it's designated SV. So since cardiac output is determined over 1 minute, it is also determined by how many times the heart squeezes or beats per minute, or the heart rate, designated HR. So cardiac output is the stroke volume times the heart rate, or cardiac output is SV times HR. It's important to recognize that stroke volume is dependent upon how much blood is in the ventricle and how well that ventricle squeezes. So the equation, again, for cardiac output is stroke volume times heart rate, and the cardiac output is measured in liters per minute. So some of the defining terminology for cardiogenic shock inadequate tissue perfusion that results from an inability of the heart to pump an adequate amount of blood. Some of the defining characteristics, which we've already mentioned, is a blood pressure, a systolic blood pressure less than 90. Lactate can be elevated, greater than 2 millimoles per liter. You'll see evidence of end organ dysfunction. So you may have cold extremities, you may have a decrease in your urine output, which we call oliguria, which means that the urine output is less than 0.5 milliliters per kilogram per hour. And then confusion can also be a symptom of decreased perfusion. You'll also see in cardiogenic shock high filling pressure. So this can be measured with central venous pressures that are greater than 10 or a pulmonary capillary wedge pressure that is greater than 15 millimeters of mercury. So we can talk a little bit more about high filling pressures in a bit. And then additionally, you may see abnormal cardiac contractility or valve problems or other things, and you can use echocardiography to look for those pathologies. So back to you, Dr. Sarah.
All right, so let's start with our case. So we have our patient, Mr. Chen. We are currently in our inpatient hospital ward. So Mr. Chen is a 50-year-old male who has a history of congestive heart failure for which he takes furosemide. His injection fraction seen on echocardiogram 1 year ago was 35%. He was admitted today and received intravenous fluids and transfusions of blood products to treat his ongoing blood loss after a motorcycle accident. So his current status currently is his heart rate is 125. His blood pressure is 87/43. His temperature is 37 degrees Celsius. His respiratory rate is 35. His SpO2 is 89% on 10 liters by face mask. Speaking in 1 to 2 words and gasping for breath. He complains of chest tightness. You hear crackles heard on auscultation. His extremities are cool with a capillary refill greater than 3 seconds. And you find his lactate is 4.
Those are some pretty severe symptoms we're seeing in Mr. Chen.
Yes, yes, it is. So do you think that Mr. Chen has cardiogenic shock? Why or why not?
So we'll give you maybe 20 or 30 seconds to type your answers in the chat box. Do you think Mr. Chen is in cardiogenic shock? And what signs or symptoms make you think he is or is not? Are you seeing any answers in the chat box, Dr. Sarah?
Yes, I'm seeing a lot come through. So a lot of yeses, and then we're getting some explanations. So lactate is more than 3 or more than 2. We're hearing crackles. We have a low systolic blood pressure, correct? Let's see, tachycardia. Shortness of breath. Yep, all of these things. Cold extremities, great.
So a lot of these signs and symptoms are of shock in general. Having the low blood pressure is indicative of shock, but there are certain signs and symptoms that lead you to believe, because we have different types of shock, that it's cardiogenic shock. So these are great answers. Okay, let's move on to the next slide. I think Dr. Paulin, are you able to discuss this further?
Yes, thank you very much, Anna. As you've just said, most of the signs we are showing in the chat box show that Mr. Chen exhibits shock. But is it cardiogenic shock? That's what we'll go through. Yes, it's a shock with a systolic blood pressure of 90, below 90, and signs of poor perfusion, indicative of critical circulatory dysfunction. Given his history of congestive heart failure and recent motor vehicle accident requiring resuscitation for hemorrhagic shock, cardiogenic shock is the leading suspicion. So if we do systematically an evaluation for type of shock to consider, we are still on the previous slide, please. So we need to rule out other causes of shock. As you can see, it's not hypovolemic because it just received a bunch of fluids during transfusion. And also, if we do the passive leg raise test, we will find that, and we can do also a POCAS. Also, due to absence of signs of infection, it is not septic shock. So meaning the diagnosis we can attribute to Mr. Chen is cardiogenic shock. So next, we need to refresh a little bit. Next slide, please.
Okay, thank you.
So to refresh a little bit our the blood flow and congestion in heart failure, we all remember this diagram of blood flow dynamic with the venous return, blood from the body, from the vena inferior and superior vena cava to the right atrium, which will go through the right arteriovenous valve to the right ventricle, then kicked out through the pulmonary simulina valve to the lungs to have a gas exchange, CO2 out and oxygen in. That blood, which is oxygenated blood, will be back to the left atrium following the pulmonary vein. When it reaches the left atrium, it will be kicked down to the left ventricle, passing through the left atrioventricular valve, which is called mitral. Then through the aorta, the blood will be pumped into the systemic circulation back to the body. So now, what happened in congestive heart failure? You can see that in animation. The way it's explaining means if any disruption happen or elevated feeling pressure in the pathway, that can lead to congestion and congested flow back into the lungs, resulting into pulmonary edema with clinical manifestation of peripheral edema due to blood pooling caused by the heart failure, inability to pump. We will have phenomena. This phenomena is central to understanding the progression from the heart failure to the cardiogenic shock. So that will also explain why the patient will be in hypoxia and will have some crackles because of pulmonary edema.
Thank you, Pauline. I think this diagram is also quite good for demonstrating why we might say that blood circulation is a tank, a pump, and some pipes. How would you describe that using this diagram? Which part do you consider the tank? Which part do you consider the pump? And which part do you consider the pipes?
So as you know, the pump is the ventricles, the heart.
So everything in this purple box, left and right parts of the heart would be the pump. Is that correct?
Yes, the ventricle, the pump, and the pipe will be the vessels.
Yeah, yeah.
The pipes will be the vessels, both the veins and the arteries. And the tanks are the pulmonary tank, where there is exchange, and the capillary tanks, and in the tissues where we pump the blood, the artery blood for exchange. So we have the pump, which is the heart, left and right ventricle, which are pumping into the pipe, which are the vessels, pulmonary arteries, and the aorta and the systemic circulation. Then the body and the lungs are the tanks.
Yeah, I think of the tank as the amount of blood that's returning to the heart. So that can be from I think of it mostly on the right side of the heart from the large veins of the body. But you're absolutely right that the lungs can also serve as a bit of a tank coming back to the left side. Thank you.
So as you can see, this animation, there is one question. What are the most common causes of cardiogenic shock? Can you give us the few causes of cardiogenic shock?
So we'll give them 20 or 30 seconds in the chat box. What are the most common causes or reasons for that lead to cardiogenic shock? Are you seeing answers in the chat box?
Yes, we can see a lot of good answers in the box.
Okay, let's reveal some of those.
So as you can see, we can, among those answers you've given, we can reveal some 4. One is cardiomyopathic causes, which are defined by reduced heart muscle function from conditions such as ischemia, cardiomyopathy, viral, and hypertrophic. We can also have the arrhythmias, which disrupt the coordinated heartbeats. Common examples are ventricular tachycardia, ventricular fibrillation, atrial fibrillation, and atrial flutter. So we can also have valve incompetence, like in case of stenotic valve, regurgitation through the mitral or the tricuspid. We can have some obstructive process, like which can be discussed in the next session. So from there, we'll pass to.
Yeah, so next we'll let Dr. Emerson tell us a little bit more, but I think it's good to recognize that anything that blocks forward flow of blood is going to cause that cardiogenic shock within the heart. The arrhythmias, I think, are a very interesting thing for people to recognize, going back to the equation for cardiac output, because it's the stroke volume times the heart rate. So if you have a dysrhythmia where the heart's unable to fill because it's too fast or uncoordinated, then that definitely will drop the cardiac output. Dr. Emerson, would you mind to review some of the signs and symptoms on physical exam that we can see to help us identify cardiogenic shock early?
Unmute.
I'm working on it. Yeah. Sorry. There you are.
All right. Thank you, Anna. So basically, the clinical examination and evaluation of the patient is basically based on what we have discussed in the pathophysiology and everything else in the previous slide. So basically, when you do the physical examination, you want to evaluate. I'll just look at the most important features of somebody who is in shock. So basically, in terms of physical examination, you look at your respiratory parameters, issues like dyspnea with tachypnea and orthopnea, nocturnal cough. You can have crickles with evidence of pulmonary edema or even pleural effusion. Then in terms of the cardiovascular examination, tachycardia with a third heart sound, commonly referred to as gallop rhythm. And then you can have an elevated jugular venous pulse and a laterally displaced apex, which basically shows cardiomegaly and narrow pulse pressures. Abdominal examination, remember, you can have ascites, which is a sign of cardiac failure, hepatomegaly, also a sign of right-sided congestion. In terms of the extremities, we discussed the issues about cord peripheries, delayed capillary refill. You can also have ankle edema and sacral edema as part of your a reflection of your right ventricular congestion. And of course, the fluid retention usually results in acute weight gain. So just remember that the right-sided congestion usually presents with the peripheral edemas, increased jugular venous pressure, cardiomegaly, and also the ascites and the angioedema. And then when you have left-sided congestion, usually presents with those pulmonary signs and symptoms of cardiac failure, and that could be one of the things that can differentiate between right-sided right ventricular failure and left ventricular failure. Also important in terms of the evaluation of the patients. Next slide. Yeah, so also in terms of the evaluation of the patient, diagnostic investigations and imaging are also very important. Remember, when you look at some of these investigations, number one, they can assist in making the diagnosis of cardiogenic shock, and also it can help you in coming up with a plausible cause of the cardiogenic shock. Then you can unmask some of the exacerbating features or causes of the cardiogenic shock. And in terms of, it also helps you to assess the amount of end organ damage that has occurred. And this can give you an indication of the severity of the shock. So when you look at it, like when you do a complete blood count, some of the things you look at is issues of anemia, which can in itself be a cause of cardiac failure and present in shock. And also it can exacerbate the degree of shock that the patient has. So it's important to look at that. And in that as well, the white cell count can also reveal whether we have an element of septic shock in the patient. Also, when you look at the metabolic profiles, important thing is the metabolic acidosis can be a reflection of hypoperfusion of your tissues. So it's important to look at that. And the troponin, basically, remember in acute myocardial infarction, troponins can be used to make the diagnosis in somebody who has got cardiogenic shock. Lactate is actually a very important parameter, particularly in terms of evaluating tissue hypoxia. So an elevated lactate is a sign of significant tissue hypoxia. But also important is that you can use serial lactate measurement to track your resuscitation of somebody who is in cardiogenic shock. So if you have got increased lactate, and then with your resuscitation, the lactate starts going down, then you can confidently say that your resuscitation is actually working. So other things like BNP, your B-type natriuretic peptide, remember it's secreted by the cardiomyocytes following an increase in your cardiac chambers when they are congested. So it also helps you to detect the cause of acute dyspnea, whether it's a cardiogenic dyspnea or it's of pulmonary origin. Other investigations, of course, include your electrocardiogram. Basically, with your ECGs, number one, you can make a diagnosis of acute coronary syndromes as causes of your cardiogenic shock. And also remember that with cardiogenic shock, arrhythmias can be a cause in terms of cardiogenic shock, and also they can make your cardiogenic shock worse. Remember bradycardia. We discussed the calculation of cardiac output, with a stroke volume times your heart rate. So if you have got bradycardia in somebody who is already struggling with the pump function, then that can exacerbate the effects of your shock. And also tachyarrhythmias. Remember that ventricular filling is quite occurs mainly during the diastolic phase of your cardiac cycle. So if you have got a tachycardia, you reduce the diastolic time, and that may then exacerbate your that may also exacerbate your manifestations of your cardiogenic shock. So it's important to do your ECG as well. Then I'm sure in the next slide we are going to talk about focus, the issue of ultrasound and echo in terms of evaluating somebody who's got a cardiogenic shock. I'll just go down to the next slide where you talk
Yeah,
about,
I wanted to make one. I want to thank you. These are excellent learning points that you're making. I think being able to distinguish between investigations that are telling you that the patient is in shock and the specific ones that tell you that it might be cardiogenic shock. So thank you for that. Another teaching and learning point that I like to make with my trainees and students is a little bit about the lactate elevation, and you said a metabolic acidosis. That is common to all forms of shock because you have decreased perfusion to the cells and they start to use anaerobic metabolism. And I think it's important clinically for bedside providers to recognize that the tachypnea or the fast breathing that the patients have is their attempt to compensate for that metabolic acidosis. So it's really important to continue that respiratory compensation for a metabolic acidosis. So for example, with our patient, Mr. Chen, who's really in extremis and struggling to breathe, if we were to put him on a mechanical ventilator and put him on a low respiratory rate, we would actually make that acidosis much worse. So if a patient is breathing really quickly, if they do progress to requiring additional respiratory support, it's important to match their respiratory rate at a higher level so that we continue to compensate for that acidosis. So thank you so much, Dr. Emerson. Can you tell us a little bit about this slide?
all right, so a chest radiograph is also quite important in assessing somebody who has got a cardiogenic shock. Remember, one of the things that we want to distinguish is whether this is just a pulmonary cause of hypoxia and those respiratory symptoms that we discussed earlier, or there's a cardiogenic element to that. So if you just look at that, or those radiographs, the white arrows there, you see, are pointing towards interstitial edema in the patient. And sometimes you can see a bedwing presentation in terms of chest x-ray. And also, if you look here, you see these little lines here, which are known as Kelly D lines, which basically point to so we said this is pecha edema, which is very alveolar edema, and then interstitial edema is indicated by those Kelly D lines. So these are some of the things that you look at when you are looking at a radiograph. But also some other aspects of it is you can see in some patients pleural effusion, okay, with the blunting of those corners there. And also you can look at the size of the heart, the cardiomegaly also can be present, which you can also make out on a chest x-ray. So like this particular patient, we can safely conclude that the patient has got pulmonary edema, which with all the history that we have got, this is a patient who's probably got a cardiogenic pulmonary edema. And I'm sure in the treatment protocols, you may consider treatment, the pharmacological treatments like your furosemide, just to take out some of the water, and ventilation. So the ventilation, of course, as we go around, we'll discuss what kind of ventilation may be required. Just remembering that if you put somebody who's got a right ventricular failure on positive pressure ventilation with a PEEP, you may actually then exacerbate the right ventricular failure. So do you want to consider non-invasive ventilation for somebody who has got a right ventricular failure? Although again, if you have got left ventricular failure, they may benefit from positive pressure ventilation. Remember, your PEEP may help to reduce the pulmonary edema. So those are the aspects of the things that you may want to look at when you assess Mr. Chan in this case. So yeah, I think I will
Thank you so much, Emerson.
Any questions?
I would like to actually expand a little bit more on your comments about right versus left ventricular failure and positive pressure ventilation, because I don't want to discourage people from supporting the respiratory system. And I'm wondering if Dr. Pearl, would you mind to talk a little bit about positive pressure ventilation in the setting of cardiogenic shock, and particularly when it's right versus left failure, ventricular failure?
Yes. So as we think about positive pressure ventilation, we should be considering the impact of the changes in thoracic pressure that occur with positive pressure ventilation on the heart and heart-lung interactions. During inspiration, the intrathoracic pressure during positive pressure ventilation increases. That has the effect of decreasing venous return, which in hypovolemic shock can be detrimental, but in cardiogenic shock may help prevent the heart from being overloaded with blood. At the same time, it is increasing the thoracic pressure, which basically raises the pressure inside the thorax and allows the heart to eject blood more efficiently to the rest of the body. So it's a form of unloading of the heart and may help increase cardiac output, as opposed to spontaneous negative pressure ventilation, where the pressure inside the chest decreases and worsens what the heart has to do, and it increases the workload. So positive pressure ventilation, or simply the use of CPAP in the non-intubated patient can be very effective in decreasing pulmonary edema and improving cardiac function. In patients who have pulmonary hypertension, this can be very different because it may, by decreasing the return to the right heart may not have the adequate filling to be able to pump blood against the pulmonary pressure that occurs in pulmonary hypertension. But nowadays, for patients with pulmonary edema, positive pressure ventilation is usually a very effective treatment in many patients, particularly in the postoperative setting, where it's been proven to improve the overall status of the patient in the post-anesthesia care unit or in the ICU.
Yeah, thank you so much. I think in general, Dr. Emerson already mentioned to give a diuretic such as furosemide, and positive pressure ventilation is usually a really quick next step for somebody who's in what we consider acute decompensated congestive heart failure, or that cardiogenic component. But it's important to then distinguish whether we have a right or left ventricular dysfunction. So thank you both for that. That's really great. So one way you can start to evaluate the heart to determine what the problem is. Is this a contractility problem? Is this a valve problem? Is this a left heart problem or a right heart problem? Is using transthoracic echocardiography. If you have an ultrasound probe in your hospital with a cardiac probe, this can be really, really helpful. It's very fast. It's non-invasive. It's non-painful. It's very inexpensive. This pocket reference was put together by some of our colleagues, primarily at the University of California in San Francisco, and it's excellent. So it's free for download. You can use the QR code. I will not walk through every section of this pocket reference, but you can notice that it tells you which type of ultrasound probe to use. It tells you in which position the patient should be, and it tells you which views you can get of the heart. So it's very, very useful for looking at the contractility, the muscles, the valves, etc. So you can really determine the contractility, whether or not the valves are open, whether or not the heart is in a normal sinus rhythm. Additionally, you can use this second page of the POCUS card and look at different parts of the left ventricular outflow tract and determine cardiac output. You can also look at the inferior vena cava, which we mentioned in our session on hypovolemic shock. So you can use the IVC or inferior vena cava to help you do a volume assessment. So this pocket card is really, really great for remembering how to evaluate the patients using this very inexpensive, non-invasive mechanism of ultrasound. On the third page of the pocket reference, it also tells you how to do lung ultrasound. This would be incredibly important in evaluating your patient for pulmonary edema that you suspect may be a component of the cardiogenic shock. And then finally, in the last section of the pocket reference, it actually tells you how to scan your patient's lower extremities, legs, for DVT or clots in the legs. So in our next session, we will discuss obstructive shock. So if you have a patient that you suspect having, for example, a pulmonary embolus, you can do a quick scan of their legs and look for DVTs, which may be the source of that pulmonary embolus, in addition to looking at the heart. So very, very useful reference and resource. I encourage all of you to download it when you can using that QR code. And again, we will put this on the Learning Resource Center as well, so you can access it there as well. So I just want to summarize before we move on. The definition of the cardiogenic shock is going to be you're in shock. You have that low systolic blood pressure, less than 90. And then you also have signs of poor perfusion. For example, cold extremities. You're going to have maybe a decrease in urine output and some confusion in your patient. You're going to have an elevated lactate because of the anaerobic metabolism when there's not enough oxygen delivered to the cells. And then additionally, you will have increased filling pressures, and we'll talk a little bit more about cardiac index. You'll have a low cardiac index in your patient. We want to determine what type of cardiogenic shock this is. We want to determine if it's right side of the heart that's having a problem. Is it the left side of the heart that's having a problem? Is it a valve problem? And we certainly want to identify early the cause of the cardiogenic shock. Is it because the patient's having an acute myocardial infarction? Did they just suffer a cardiac arrest? Is it from a dysrhythmia or arrhythmia, et cetera? And then Dr. Paulin and Dr. Emerson helped us walk through some of the key investigations that we would use. And then we also talked about echocardiography and lung ultrasound. In more advanced centers, we would also consider invasive hemodynamic monitoring, which we'll talk a little bit more about from our cardiothoracic ICU experts. And this would include things like the arterial catheter, the pulmonary artery catheter, and some other more specialized devices. So with that, I'm going to hand it back over to Dr. Sarah.
All right. So going back to our patient, Mr. Chen, we have results from his imaging and his labs that are done. So his EKG shows sinus tachycardia. His chest X-ray shows pulmonary edema. On his echocardiogram, he has a moderately dilated right and left ventricle, noticeably depressed left ventricular contractility with ejection fraction estimated at 20%. No wall motion abnormalities. He has a full inferior vena cava, not collapsible with respirations. And you do a lung ultrasound, which shows B lines. On our labs, we have a lactate of 4. Our natriuretic peptide is 4,000, and our troponin is 1.4. And so you can see that with the pulmonary edema on his chest X-ray and his lung ultrasound, he has acute decompensated heart failure. You can see that with his echo, that he went from 35% from the year prior to 20%, and that his labs are consistent with poor perfusion, same with his lactate and his BNP. So the suspicion of cardiogenic shock is confirmed. The other thing is that with our EKG, we don't show elevated ST changes. So there's not a myocardial infarction that's happening. And so the acute coronary syndrome and revascularization is not indicated in this patient.
Wonderful. We are so fortunate today to have a cardiologist on our panel. So I'm going to ask Dr. Dan Gerber to talk to us a little bit about acute coronary syndrome and some ways in which these cardiogenic shock patients can present.
Hi, everyone. My name is Dan Gerber. Thank you for having me. I think that, the first thing that I would say is, it seems like we've pretty clearly established that this patient, Mr. Chen, is in cardiogenic shock. Like everyone said, he meets classic shock criteria. He's hypotensive, he's hypoperfusing. And then the way that I think about it is he has multiple signs of hypoperfusion, low cardiac output, with elevated filling pressures. And with the echo and the with his IVC and his chest X-ray and his BNP, he has biventricular congestion. So I think in terms of profiling, he has a biventricular congestive profile, biventricular dysfunction. And at least at this point, we try to branch cardiogenic shock into acute MI versus heart failure shock. And the reason is that the two etiologies behave very differently, and it also directs your management. So as a first thing, I would say that it's this is acute MI or not acute MI shock. I would trend that troponin. This could be a early presentation, and so if his troponin goes through the roof, then I would definitely consider at least exploring options for revascularization. But otherwise, he would be heart failure, cardiogenic shock, and then further we separated into de novo versus acute on chronic. And again, that just helps you wrap your head around why is this patient getting sick and how to manage them. And so this would be an acute on chronic heart failure, cardiogenic shock. In terms of management, this is a really nice kind of infographic that's worth looking through a little bit more in depth. But I think the 10,000-foot view is you're desperately trying to look for some way to improve their function. And the number one thing we want to look for is, do we need to revascularize? Are they ischemic and they need revascularization? It is the number one cause of cardiogenic shock. And it is the item that we have the most data since the 1990s that intervening on improves outcomes. So that's number one, is identify acute MI shock. Other things like we talked about, valves, arrhythmias, both fast and slow, pericardial disease, which falls more into obstructive shock. Those are all important to identify as areas for intervention and improvement. In terms of optimizing the hemodynamics, the way that I like to think about it and the way that this infographic kind of goes through it is, first, I want to optimize loading conditions. So I think of that as preload and afterload. In this patient's case with a weak ventricle, when he first came in and he was in hypovolemic shock after the motor vehicle accident, he probably needs additional preload. And so it's not inaccurate to give him volume. And then now, obviously, we're in a different situation where our filling pressures are very high. And in this case, we're going to actually have to take away volume whenever he can tolerate diuresis or renal replacement therapy. And so in terms of optimizing loading conditions, I think of preload and then afterload. And the afterload in this case is his blood pressure, and his blood pressure is too low. And so we need to restore perfusion pressure. And I think that for the most part, out of multiple small trials, it seems that norepinephrine is probably a good, safe first line vasopressor in basically almost all forms of shock, and I think in cardiogenic shock as well.
Dr. Dan, may I just insert a comment there? Many of our learners are in resource-constrained settings, and so norepinephrine, or what's also known as noradrenaline, may not be available, and the only thing available is adrenaline. Would you use adrenaline or epinephrine in that situation?
I would, and I mean, I think historically we used a lot of dopamine and epinephrine, and the literature, again, out of small trials over the past 10 years or so, suggests that dopamine, back in SOAP in 2010, but dopamine is slightly more arrhythmogenic, and epinephrine is probably also a slightly more arrhythmogenic than a norepinephrine plus inodilator, which would be a dobutamine milrinone choice. So I think if you have access to those drugs, then we're slowly shifting more towards norepinephrine to restore perfusion pressure, and then an inotrope to improve contractile function if they're still hypoperfusing. If you don't, then I think epinephrine's a fantastic choice. I
It's
think
better than
TMS
not giving
accomplished
anything at
it.
all.
It's definitely better than not doing anything at all. And so I would try to, restore adequate preload, restore a perfusion pressure with whatever drug you have access to. And I think that if you have access to norepinephrine, that's probably an easy first line drug. And then once you've done those, if there's still have evidence of hypoperfusion, things like the lactate and the cool extremities and the poor cap refill, renal function, urine output, altered mental status, LFTs, all of those signs that we've already gone over, that's when I reach for the inotrope. If you're going with epinephrine, it makes life a little easier since it's one drug to rule them all, and you'll raise the blood pressure and give yourself an inotrope. And then in the meantime, we obviously have to manage other organ dysfunction. Most people who die in the cardiac ICUs die of neurological and pulmonary disease. And so, like Dr. Pearl was discussing earlier, managing the pulmonary edema, the respiratory failure, managing the renal failure. If you can't diurese, then they might need renal replacement therapy, even just to manage their volume status. And then the bottom line, I think, is very important. If you have refractory shock, meaning that you've done those things that we just discussed, and they still have signs of even stable shock, meaning that they're on epinephrine or they're on norepinephrine and dobutamine, and the lactate is still 3 or 4, and they're still having pulmonary edema, and they're still not making much urine output, that's a bad sign of refractory shock. Even if it's not worsening, the failure to improve is a bad sign. And so that would be the time to reach out to a cardiac center if there's one nearby, and consider escalating support, or at least escalating to invasive hemodynamics to help guide you.
Great. Thank you so much. So once again, the most common cause is severe heart attack, isn't it? Can you go through this algorithm for us, Dr. Dan, and maybe specifically talk a little bit about, if you don't have a cath lab or a way to do revascularization using percutaneous methods?
Yes, of course. So we learned the mnemonic like Mona Bash back in medical school, which basically goes through the first line interventions up at the top, which is typically pain control. So I mean, the M is morphine, the O is oxygen, which you really don't want to just put oxygen on people who have a normal saturation. There's some small studies that show potentially a signal towards harm there, but certainly if they're hypoxic, you want to support them with oxygen. We give nitrates, and the caveat there is to be careful of an RV-MI. So if you have a inferior RV STEMI, and especially if you can take a look by ultrasound, if you see that the RV looks severely dysfunctional, then I would just be a little bit careful with nitroglycerin, because it can drop the RV preload. So just the caveat there.
Can you remind the audience, Dr. Dan, when you're having a right-sided heart attack, in which leads on the ECG would you see ST changes?
Yeah, that's a great question. So what would kind of trigger you is an inferior STEMI. So if you're seeing leads 2, 3 in AVF with ST elevations. But the other thing to be careful of is in your septal leads, so V1 through 3. If you have deep ST depressions, that can be a posterior MI. It's basically an upside down posterior MI. And so if you have an inferior STEMI, then it's often helpful to do posterior or right-sided leads. So taking your V1 through 6 and then extending it out to V7 through 9, or switching the V4, 5, 6 over to the right side of the chest, and seeing if you have an RV MI or if you have a posterior MI, because that can very much change management, change their prognosis, and changes management.
Great. Thank you.
So the other items, the antiplatelet therapies, so aspirin and a P2Y12, so the clopidogrels, prasugrels, ticagrelor, Cangrelor if you need an IV version and if that's available. But great data for those, especially if you're not going to the operating room very quickly. Then there's excellent data that you want to start both of those as soon as possible, and then anticoagulation. And really, if you're planning a non-invasive approach, meaning you're not going to the cath lab immediately, then low molecular weight heparin has a slightly better outcomes than heparin, but worse if you're going to the cath lab and having procedures because there's a higher bleeding risk. So heparin, low molecular weight heparin as your anticoagulation.
Can I just paint a scenario that we're in a resource constrained setting? We don't have a cath lab and we want to start aspirin and another antiplatelet agent. Can I ask Dr. Emerson and Dr. Paulin, which of those agents are available in your setting, number one? And then number two, how would you manage the anticoagulation? Would you start a heparin infusion or sub-Q heparin, or would you start with a low molecular weight heparin such as Lovenox? Can I ask maybe Dr. Emerson?
Currently in Zimbabwe, I think we have both aspirin and clopidogrel. I'm not sure which other ones are available, but most of these are mainly available for in private sector. In the public sector, maybe aspirin, the cardioaspirin, but I'm not sure we can get clopidogrel at the moment. For most of our for the patients, I think what is mainly available is unfractionated heparin. The low molecular heparin are found in maybe particular institutions, so not necessarily readily available. The other problem we may have is access to infusion pumps. So basically, when we are dosing our heparin, in most instances, it's probably intermittent boluses, dose boluses, rather than infusion of the heparin.
Thank you, Emerson. And Dr. Paulin, you have probably worked in more varied settings than anyone else on the panel, multiple different countries and multiple different settings. What has been your experience about what is available for antiplatelet agents and anticoagulation for these patients?
So for anticoagulation, I think it's pretty the same as described by Emerson for the low molecular weight, and sometimes we have also to use the heparin using the pump. So as you said, in the private sector, there is always possibility to juggle and get everything we can get from the high income countries. So for the public,
if only all of our patients were in private. This is unfortunate, isn't it?
Yes, for the public sector, so that's where we to look on the essential drugs in the hospital. So the low molecular weight can be found and can be monitored by following the platelets. And when you start using, also we can use also warfarin, but that time you need to follow on INR for the hospital where we can find them. So there is some bedside small machine of INR, which can be used and also can be given to the patient for himself to follow when he is out of the hospital. We've used them when we established the cardiac open heart surgery program. So we could find some personalized INR test small machine, so the patient can go with it in his settings and use it regularly. So I think the system is pretty the same as in Zimbabwe, quite affordable in private, but difficult to manage in the public system.
Okay, thank you guys so much.
Yeah. Can I ask you guys, so our literature would suggest that if you're planning a non-invasive approach, meaning they're either not a candidate for to go to the cath lab, or they don't need to go to the cath lab, or they don't have access to a cath lab, that any of these anticoagulations are probably fairly equivalent with some of the longer acting being slightly superior. When you don't have to worry about the bleeding risk of a procedure. But how long do you continue? Do you 48 hours? Do you do it until discharge? How long do you continue the anticoagulation component?
A great question.
So I think what we do is when the patient is still in the hospital, we continue until 48 hours. So, and we keep checking. So if there is need for him to continue until discharge, most of them, they need it until discharge. So we'll send them out, but put a clear system of monitoring results if they are thinking it's discharge. See if some of them are from the very far villages. So we need to establish a system in the community how to make the follow-up.
Great.
Or on phone or SMS, thing like that.
Yeah, from my side, I think a disclaimer, I'm an anesthesiologist and critical chemist. So basically, most of the management post the acute period is mainly done by the cardiologist. I'm not too sure how they usually manage their long-term anticoagulation, but what I know is they usually keep them on the antiplatelet drugs for a significant period. It's something that I will need to kind of check with them and find out how they really do it.
These are great questions and great learning points. Thank you. For the sake of time, I'm going to push us forward and see if Sarah has any updates on our patient, Mr. Chen.
Yes. So, Mr. Chen, we bring it full circle. We talk about his treatment plan. So, under the oxygen and assisted ventilation, we place him on a non-invasive positive pressure ventilation support, which he tolerates really well, and his SpO2 improves to 92%. Talking about preload and afterload, so using diuretics, we give him 40 milligrams of furosemide for volume overload. And his urine output increases to 1.5 liters over 2 hours, which is really great. And I bet he's breathing much better there. And then inotropes vasopressors. So his blood pressure is supported with noradrenaline and dobutamine. It started to support the contractility of his heart, so for the inotropy for dobutamine. His heart contractility looks slightly better when reassessed on echo, although it's not going to, fully get him back to normal, or maybe not even to his 35%, but at least a little bit better than the 20% in his acute decompensated state.
That's great. So one thing that, we've talked a lot about diagnostics and physical exam signs and symptoms of cardiogenic shock. And we know that cardiogenic shock is related to a decrease in cardiac output. I'm wondering if Dr. J would be able to help us understand, how do we actually assess cardiac output?
Yeah, absolutely. It's a good segue to that conversation. So since cardiogenic shock is really low perfusion state due to impaired cardiac output, what are some of the ways that the people measure cardiac output? Maybe we'll take 20 seconds or so to type it in the chat, and then we'll go over some of the commonly used methods.
Okay. So this is over to you, learners. Put your answers in the chat box. How can you assess cardiac output?
I see some comments there already. Urine output, which is a great metric of perfusion. So you can say that the body is getting the blood it needs, especially the kidneys, but may not give you a number to track necessarily. Echocardiogram, stroke volume. And I see blood pressure there, and I will say, in my perspective, I think we see a lot of cardiogenic shock where your blood pressure or your mean arterial pressure can be normal, because mean arterial pressure, going back to the equation that Dr. Crawford mentioned earlier, that MAP equals cardiac output times systemic vascular resistance. So you may have a normal MAP in the setting of a high afterload, which is frequently seen in cardiogenic shock, but the patient may have narrow pulsatility in the arteries and a really poorly perfused state. And the other methods that you guys have mentioned, so we will go over them in sequential slides, but echocardiography to both look at the chambers of the heart, which tells you about the left ventricular versus right ventricular failure, assess any valvular issues that might be present, whether it's rheumatic heart disease and stenotic valves, or regurgitant lesions from endocarditis or chronic valvular disease, or ischemia-related changes like papillary muscle rupture, etc. And so looking at the heart is a big thing. And then we'll measure stroke volume using point of care ultrasound, which is becoming more and more popular, and tracking that cardiac output change over time. And the invasive methods to do that would be a pulmonary artery or a Swan-Ganz catheter, which uses both thermodilution, or we may use the Fick principle by measuring the mixed venous oxygen saturation after drawing the sample from the pulmonary artery port. So we'll go over these two in the next subsequent slides. So the way I understand the left ventricular, this is my favorite personally, the left ventricular outflow tract velocity time integral, or VTI measurement, to track cardiac output, because as long as you have access to any point of care ultrasound machine and can get an apical 4-chamber going to 5-chamber view, this can be easily tracked over time. So the analogy I think about is, think about the left ventricular outflow tract as the garden hose, and it's connected to the water source, which is the heart. So if you turn on the water, which is the heartbeat, then the hose is going to have water coming out of there, and that water shooting out of it is going to be the stroke volume. So if your hose is wider, you're going to have more stroke volume. So that's the LVOT diameter. And if your water is flowing really quickly, that the velocity of blood coming out of the hose is really fast, then in a certain amount of time, you get more water out of the hose. So that's the principle we're sort of using. So the LVOT, which is the left ventricular outflow tract, is the area immediately below or proximal to the aortic valve. And we think of it as a circle for easy estimation of area. So in the parasternal long axis view, we can measure the LVOT diameter, and then we divide this diameter by 2 to get a radius. And because we consider this to be circular, the area of the LVOT is pi r square. So that's going to be our first part of this equation. Then the second part of the equation is going to be how much blood is ejected through the heart in one heartbeat, right? So what distance does the red blood cell travel when the heart squeezes one time? And so we use, going back to calculus and math, we use this velocity time integral graph, which is obtained by putting a pulse wave Doppler into the LVOT, and you get this trace which shows blood is going outwards from the left ventricle into the aorta, so it's below the x-axis. And when we trace it, the machine calculates the area under the curve, and the velocity time integral tells you the distance the blood travels in one heartbeat. So now that we have the area and we have the distance, we can multiply the two of them to get the stroke volume, which basically, if you think about it, is the volume of a cylinder, because it's area times height. And so pi r square for the LVOT area, height is from the velocity time integral that the machine calculates, and you multiply the two to get stroke volume. And if you have access to the monitor or just measuring the pulse of the patient, you can multiply by heart rate to get cardiac output. Now, this seems very complicated, but practically, if you're not going to measure the LVOT area or measure the heart rate, you can also just track the VTI by itself. You can check one number, make an intervention like adding dobutamine or noradrenaline, or in a hypotensive, hypovolemic patient, maybe a fluid challenge. And if the velocity time integral increases, then the cardiac output has gone up because the patient's LVOT area is not changing from minute to minute.
This is very helpful. Thank you so much, Dr. J. And I just want to reiterate, it may seem a bit daunting or a lot of information for those not familiar with echocardiography. But I think if you download that pocket reference and walk through it step by step by step, it really is quite easy. And I think this is another reinforcement of why it's really important to understand the equations for blood pressure and cardiac output, so you can really monitor your patient and make sure your interventions are working. Thank you.
Yes, and going back to our pulmonary artery catheter, obviously a lot of literature over the past 2 or 3 decades. So the pulmonary artery catheters were very popular and then became very unpopular, and now they're coming back into clinical practice a little bit more. But in the cardiogenic shock patient population, they're still extremely valuable because they allow to measure the cardiac output and track it via 2 different methods. So the thermodilution method is basically when we inject some cold saline through the central venous port, which is around the right atrium over here, and then measure the temperature change that is detected at a thermistor that's placed more distally on the PA catheter. And the thermistor measures that temperature, that difference in temperature over time, and uses that to calculate the cardiac output change. And so that's one method. And the second method is the Fick principle. And the Fick principle measures cardiac output by determining the amount of oxygen that's consumed by the body, and then dividing it by the difference in oxygen that is in the oxygen saturation of the arterial blood, so the SaO2, and the oxygen from the mixed venous blood, which is obtained from the pulmonary artery port right over there. And so that's the Fick method of doing it. There are calculators online that you can use if you have a mixed venous saturation from the pulmonary artery catheter and an arterial saturation of oxygen, which if your patient is saturating, 99 or 100%, then it's reasonable to use that as a surrogate if you don't have an arterial blood gas to measure that. And then the amount of oxygen consumed by the body usually depends upon the age and the height and the weight of the patient. And so calculators can calculate the estimated cardiac output if we give them these numbers and plug them in.
That's great. In regards to the Fick principle, also for the participants' sake, I wanted to just alert you that on the Learning Resource Center, we have a really nice YouTube video that will help explain the Fick principle in a little more depth. So if you really want to learn more about that, we do have a video available for you on the Learning Resource Center.
And then I'll quickly go over these. And to be honest with you, even in our hospital, we don't use very many of these methods, but these are used in several hospitals, at least in the United States and also probably elsewhere in the world. So some of these are half invasive, half non-invasive measures of cardiac output. And so, for example, the lithium dilution-based devices, or the LiDCO, where you have an arterial line and you inject a little bit of lithium in it, it measures the lithium concentration changes, calibrates the machine, and then using your arterial waveform and a mixture of the lithium dilution as well as the pulse contour analysis will give you a cardiac output. Similar to that is transpulmonary thermodilution, where a central line and an arterial line is placed. And in this case, the arterial line has a thermistor, or a temperature changing kind of monitoring device. And so you inject cold saline in the central line, the arterial line detects the temperature change and uses some algorithms to calculate the cardiac output. Many other systems that use arterial waveform calculations and pulse contour analysis. And the last two, thoracic bioimpedance, is a very interesting one, where you use a monitor on the chest, inject a little bit of current, and then it measures the time delay in seeing what the voltage comes up from that current that's injected, and uses that to calculate cardiac output. So it's using kind of like Ohm's law with voltage equals current times resistance to calculate cardiac output in a way. I think that's the easiest way I can describe it. I don't know the exact mechanical details of these devices. And the last one is the aortic Doppler, which is available in places and relatively easy to use. So it's put in like an orogastric tube. It sits in the esophagus about 40 centimeters from the lips or teeth, and then it measures the aortic blood flow. It has a little sensor which is angled, so it can measure the velocity of the aortic blood, and it can measure it with each heartbeat and measure the changes to that aortic velocity profile, and then correlate that with the cardiac output changes.
Yeah, I think it's funny that you mentioned, I don't know the exact mechanism with which all of these devices work. I think it can be quite confusing, and there's a lot of different devices out there. I certainly don't understand the exact mechanisms of all of them, but I do have one question for you, Dr. J. You are at Stanford University, which is one of probably the most highly resourced settings that you could possibly have for these cardiac patients. Can you tell us which of these additional devices do you actually use in your cardiothoracic intensive care unit?
In our cardiothoracic intensive care unit, for the patients in really bad cardiogenic shock, we're primarily relying upon the pulmonary artery catheter. And my personal favorite is the mixed venous oxygen saturation from the PA catheter, because that tells me the difference between what the heart is able to deliver in terms of oxygen to the body, and then if that is sufficient to meet the needs of the organs in the state of shock. Because if that mixed venous oxygen is normal, like 65, 70%, I'm very satisfied that the body is getting the oxygen it needs. It's able to use the oxygen delivered to it, and then you still have 65% of it returning back, which is a normal range for the mixed venous. So that is my favorite one. For patients who do not have a pulmonary artery catheter, because that's very invasive, you have to put it in patients and can be risky in certain circumstances, my favorite cardiac output measuring technique is to follow this LVOT, velocity time integral, over time, So I'll measure it, I'll do an intervention like add an inotrope or titrate some medications, and then I will measure a VTI in a few hours again to see if it's improving or going in a good direction. And for reference, a normal velocity time integral will be anywhere between like 18.5 to 22.5. In the sick patients, usually, even 15, 16 with a high heart rate can get you a reasonable cardiac output, but that's a rough number that I'm looking for. The higher, the better. I personally don't use any of these devices. I mostly use the PA catheter and the echocardiography, like in the previous two slides.
That's actually good to hear, because these are all specialized devices with additional equipment and things that might be a barrier for places that have resource constraints. But I think ultrasound and point of care ultrasound is becoming more and more widely available. So it's really great that we can use those things just as well. I believe Dr. Pearl had to leave at 8 o'clock. So I'm actually going to put a little pressure again on Dr. J and maybe Dr. Gerber to talk about these next two slides. So Dr. J, do you mind contributing here as well?
Yeah, so the cardiac index is a very important concept. It basically accounts for the cardiac output, just gives you a certain number, but whether that number is sufficient to meet the needs of the patient's body and end organ perfusion is dependent upon their body surface area. So to normalize it to patients with different body habitus, we divide the cardiac output by their body surface area, which again, we can use calculators to obtain. It's slightly different than the body mass index or the BMI, but again, uses a height and weight calculation. And we divide the cardiac output by the body surface area to index it to the specific patient. And so normally our cardiac index ranges from between 2.5 to 4, and in the very, very sick patients in the ICU, sometimes even 2.2, 2.3 we'll say is barely acceptable to meet perfusion needs. Now, again, this is just one of the things we're following. I think we started the lecture today by talking about the lactates and urine output and other markers of perfusion. So I think we're looking at them all together to see if the patient is getting all the blood they need and the organs are happy.
That's really good information to have. When I was putting the slide together, I was looking for normal indices for cardiac, or for the cardiac index, normal ranges, and it does vary a bit in the literature. So you would say 2.2 to 2.3 is the very lowest end of acceptability for a cardiac index.
Yep.
Great.
The next slide is going to go into our world, and we do a lot of mechanical circulatory support here at Stanford. And
can I just quickly chime in, and then I'll let you take back over? So
yeah.
If I would just argue, if your index is 2, it's not good. But if your lactate's clear and they're peeing and they're mentating and the LFTs look good, sometimes perfect is the enemy of good. And so I don't know if that I would take that I would intentionally drive up the index if they're otherwise perfusing.
That's an excellent point. I think also trending it, if you're able to trend it, and you see clinical improvement because of an increase in your cardiac index would also be good information. Is that fair?
Yes, I think so.
Yeah, and I think I will say one more thing. Like, that's why I was saying, I think I don't look at any of these in isolation. I think it's good to look at it in terms of lactates, urine outputs. There are also problems with both the echocardiographic cardiac output as well as the thermodilution cardiac output. For example, in patients who may have tricuspid insufficiency or regurgitation, the thermodilution may not be accurate because of that. If patients have aortic insufficiency, then calculating cardiac output by left ventricular outflow tract velocity time integral may not be accurate because that doesn't quite capture the true forward flow of the heart. So I think all of these methods, including the non-invasive ones, which we don't use very common, every single one of them has a list of caveats. So whichever ones you're thinking are going to be most applicable to your practice, I think it's worthwhile investigating that method in a little bit more detail so you become the expert at it and know the caveats of when the numbers might confuse you. But at the end of the day, I think if the patient looks pink and is making good urine and their lactate is normal, I think then we can say they're well perfused. I think that's why looking at this cardiac index number with everything else going on with the patient is very helpful. Thank you for that, Dr.
Not
Berger.
all patients are pink, though, Dr. J. Not all
Yes,
patients.
you're right. As in, like, oxygenated, I meant. Sorry about
that. Great. Thank you so much. I think those are great points and learning for all of us. Can we talk about mechanical support for the heart?
Yeah. And Dr. Gerber can chime in as well because he also manages a lot of these devices. But we'll go over it in brief. This could be an entirely new webinar of its own, but we start with the intra-aortic balloon pump, which is very helpful for both augmenting coronary perfusion pressure. So it works by a balloon inflating in diastole. So it sort of pushes blood back towards the heart, towards the aortic root where the coronary arteries come from. So the coronary arteries get a lot of blood flow. It also then deflates in systole, so it creates like an artificial vacuum-like effect and makes it easier for the struggling heart to pump blood forward. And so it reduces the afterload. It generally increases stroke volume, can give you about 0.5 to 1 liter of cardiac output support, and reduces the left ventricular end diastolic pressure and volume, which are all good things for a ventricle that might be struggling. So it's really good for both left-sided failure, but also sometimes helpful for right ventricular failure as well. The next, going down the line.
Question about the balloon pump. Does it improve outcomes?
We'll let Dr. Gerber answer that one because there are many trials that did not show much of a benefit. And I think in the European Society of Cardiology, they have removed or gone away from using balloon pumps a lot. But at Stanford, we used a lot of balloon pumps. So I'll let Dr. Gerber chime in.
Yeah. I mean, the most clear answer is no. In the largest trial that's it's ever been done in MCS, IBP Shock 2, you couldn't have two more overlapping curves between balloon and control. I think that said, there's similar to PA lines. There's a lot of observational, like retrospective data that's growing about identifying subpopulations that do benefit. And I think anecdotally, we do see some patients that have those, 0.5 to 1 liter improvements. And then we definitely have patients where you put in the balloon and there's absolutely no change in their hemodynamics. So I think patient selection here is critical, whereas every other device on this list is a pump. And so the higher they flow, the more support you get. And so patient selection is very important for the balloon pump. And again, I think probably you're looking for a dilated ventricle. If they have active ischemia, that's helpful. If they have severe MR, that's helpful. And then it tends to be patients who have a high SVR that benefit from a balloon pump. So if you have someone who's vasoplegic, who's very hypotensive, who has a very low cardiac output, it's probably not somebody that I would try a balloon unless you really have access to nothing else.
Great. Okay. Thank you. And just to note, we only have like 1 minute left or 2 minutes left. So
we'll do 20 seconds on these two. This one, these machines just take blood out of the left ventricle, put it in the aorta. So they basically bypass the left ventricle directly, but doesn't help with oxygenation or ventilation. And as you head towards the last part of the slide, on the veno-arterial ECMO side, you get both cardiac and pulmonary support for the failing heart and the failing lungs. Obviously very resource intensive and very complex to manage on a day-to-day basis. And in short, they only allow for the body to get blood flow while the heart recovers. They don't directly make the heart better. If anything, they add more stress to the heart.
Can I ask you which of these you use in your unit?
We use the balloon pump, the Impella devices, and veno-arterial ECMO. The tandem heart we have used sometimes, but it's not so commonly.
Okay.
But we use all of them.
Dr. Banguti, which of these devices have you seen used in your settings?
None of them. I've seen in Belgium once this IBP, IIBP, but just I saw it on the table, but I never seen one used. But in Africa, in Rwanda, none of those are in used, and I've never seen one of them.
Dr. Emerson.
The ECMO I've seen while like failed to get out of the pump, and we put the patient on an ECMO during cardiac surgery, but not a ECMO for the patient to get out of the hospital.
We don't have access to any of those devices at the moment.
I figured that might be the case, but maybe one day. And I think Dr. J made a really important point that these really are bridges to let the heart recover, bridges to transplant. Dr. Sarah, can we wrap up the session? How is our patient doing?
Of course. So back to Mr. Chen. So 2 hours later, he's breathing easier. Since we got all of his fluid off, he was downgraded to 6 liters of oxygen by nasal cannula instead of having the positive pressure ventilation. His vital signs are stable, so normalization of his blood pressure. He has produced 2.5 liters of urine after we gave the 40 of furosemide. His noradrenaline and dobutamine infusions are decreasing, and then he's asking for a hamburger. So always a good sign if they want to eat something or they have an appetite.
Wonderful. Thank you so much. I loved this discussion. So I just really, again, want to thank all of our amazing panelists. I love to hear about the different situations and different resources across settings. So really, really grateful for the high resource settings of Dr. Jay and Dr. Dan, and always love to hear the solutions and challenges in less resource settings. So really, really grateful for the more realistic perspectives of Dr. Emerson and Dr. Paulin. Thank you so much. We are at time, so we do not have time for questions and answers. However, I want to reassure all of our participants that we are recording the questions that you put into these webinars and the questions that you submit when you register. And we will, over the 12-month series, have 2 frequently asked questions sessions where all we do is answer your questions. So be reassured that we will get to your questions, if not today, then the next in the next sessions. So please join us on February 19th. We're going to talk about the last of the 4 types of shock. We're going to talk about obstructive shock, where we will cover things like cardiac tamponade and pulmonary embolus. Again, all of the resources are on the LRC. That link was placed in the chat box. You have a QR code in the slides, and it's also sent out with registration. So please make sure you can access all of the resources there. All of the participants who attended this full session will automatically receive a certificate of attendance. You will also receive an email from Stanford CME within 5 business days. It will contain detailed instructions on how to complete an evaluation so you can claim CME. Please follow those instructions on how to complete the evaluation and get your CME. And so with that, I want to thank my panelists again, and we will see you in February. And I hope you take good care. Thank you, everyone.